Hello, I'm Dr. Donald Jurivich. I'm a UND professor of geriatrics, and I'm the director of the program called Dakota Geriatrics. You can see the website information there on the left-hand side of the slide. And today, the presentation is Age-Friendly Healthcare, an Introduction. So, the goals for this presentation are to firstly report the geriatric 4Ms. We'd like to know how to apply these 4M assessments and then how to create 4M action plans. And I just have a nod here to this 100-year-old man who's running marathons, Ed Whitlock from Canada. Just an amazing example of how successful aging can be accomplished. The 4Ms are part of a consortium of organizations that distilled the basics of geriatric healthcare into what matters, medication, mentation, or now we like to refer to it as mind, and mobility. So firstly, the what matters is to basically know and align care of each older adult's specific goals for their health. In terms of medication, we want to reduce unsafe medications and the overall burden of medications. In terms of the mind, we want to prevent and treat depression, delirium, and dementia. In mobility, we want to make sure that people move safely and avoid falls. So it turns out that research shows that the 4Ms, when they are practiced as a set, really do work. In terms of asking what matters most to the older adults, you find that there's less hospitalization, and when there is hospitalization, it has shorter lengths of stay. There's more comfort care being utilized as a result of asking what matters. In terms of medications, there's a reduction in the burden of medications, particularly unsafe medicines, and as a consequence, there are fewer adverse drug events. In terms of mentation, there's better delirium detection, better depression treatment, and better management of dementia, such as Alzheimer's disease. And of course, in mobility, we see fewer falls, and that helps reduce overall costs. And in general, all of these 4Ms help improve or reduce the costs of medical care, which is really a good thing. So when we ask or focus on what matters to the older adults, we have to be mindful that somebody who's highly functional may want to continue to feel strong and active and want to travel and be with their grandchildren. Whereas on the other hand, a frail older adult, although they may have the same aspirations as a highly functional older adult, they may find that they have some limitations. And so in some cases, it may be just really understanding comfort care and being with friends and families. And we also need to recognize that older adults have different levels of interest in maintaining their health. Some really are highly invested. They want really good sugar controls. They want good blood pressure controls, which, by the way, good blood pressure control at 120 systolic is now found to be the most important way to prevent stroke and heart attacks. In terms of more laissez-faire patients or older adults, they may not be so worked up about keeping their glucose levels under strict control, and they may be less inclined to worry about their blood pressure. But again, it's important to understand what the patient's goals are and work within that time frame. And potentially for older adults that have a more relaxed view of their health is to provide them with education as to the importance of a stronger healthcare plan for them. So you may recognize Leonard Nimoy here from Star Trek. He had the famous line, "Live long and prosper." And that really is something that we need to think about when we ask what matters to the older adult. Firstly, the basis for a lot of what matters is depending upon what's the remaining life expectancy of the older adult. We want to also understand what their functional trajectory is, how well they can do their activities of daily living. Are they needing help on their instrumental activities of daily living? These are all questions that we need to ask, because if the answer is yes to some of those, then there's a likelihood that there is a rapid trajectory towards the latter part or the end of life. And so we need to identify those milestones and work within that framework, as well as educate the older adult and their family members as to what those trajectories might be. And that leads us to that third point here, which is knowing when medical care is futile. I had, as an example, a patient who was late 80s who wanted to get a knee replacement, who was quite functionally impaired. And when we had a discussion that her remaining life expectancy was about 3 more years, she gave second consideration to having the surgery. We also need to think about decisional-making capacity. Does the person or the older adult have the ability to understand what's being asked of them? Do they understand the consequences? And can they provide that information back as a teach-back moment? And then finally, we need to think about what's the mission of the older adult. When they wake up in the morning, what do they look forward to doing? And if the answer is not much, then you know you've got an issue related to either potentially depression, dementia, or just a consideration that they may really have recognized that they are in their final period of their life. So you can start the conversation with what matters by asking what's important to you currently, or what brings you joy. So these are all scripted questions that you can use, and you're certainly welcome to copy these from the slide to use them in your everyday practice. Another strategy is to do what's called target practice. You can have all these little 3x5 cards or stickies or whatever you want with the different names of things that might be important to the older adult, and then you can ask them to put these stickies onto the bullseye, next to the bullseye, and further out, with the further out stickers representing less important issues. So it helps the older adult triage or prioritize what's most important for them. So I mentioned that it's important to consider remaining life expectancy. And so when people are frail, and presumably in your training that you have come across how to recognize frailty, it's important to consider what the remaining life expectancy is as people become increasingly frail. And as you can see, that a normal, healthy 70-year-old has 18 years of remaining life expectancy, whereas a frail individual has 3 or fewer years left of life expectancy. So there's a really big difference. And so the conversation between the healthy versus the frail older adult is going to be significantly different in terms of identifying what matters. There's other factors that are going to impact life expectancy, and both healthcare workers and family members don't always recognize these facts that really do influence life expectancy and, in fact, shorten it. So if somebody has a low serum albumin as the first point, that's a really strong predictor of shortened life expectancy. Unresolved delirium has 100% mortality within 1 year. People that get recurrent acute care are often at the end of their life. And a vivid example of that here recently is President Jimmy Carter, who at the age of 98 decided that after multiple hospitalizations that he would enroll in hospice care. Frequent falls are a predictor of future death, and of course, dementia. So I'd like to summarize by saying that the geriatric 4Ms include what matters, medication, mobility, and mind or mentation. The specific tools are available to assess each of these 4Ms, and we'll be discussing this in future presentations. We want to use the 4Ms to create an action plan. And so every time you have an assessment, whether it's a screen negative for dementia, for example, you still want to have an action plan for people who don't have dementia. Namely, you want to make sure they have good blood pressure control, you want to make sure that they are exercising, and that they are doing cognitive stimulation, right? As opposed to somebody who screens positive for dementia, which has some additional interventions, including medications that you might want to apply. So again, if you can look at the bifurcation of screen positive and screen negative, there's going to be an action plan for each of those 4 M's. And then finally, the point that I want to make is that it's important to really get a handle on remaining life expectancy and to have a conversation with the older adults so that they can better plan for those remaining years that were expected. And mind you, sometimes people have more life expectancy than they really anticipated. I had a 96-year-old who I said, "Oh, we better start planning for the next 10 years." And she looked at me and says, "What are you talking about?" I said, "Well, you're very highly functional, and the fastest growing group in the United States right now are 110-year-olds. And she says, "Oh my, I guess we better start planning." So with those revelations, I think you can have a good conversation with the older adult and help them through the 4M assessments and action plans. Thank you for your attention. Bye-bye.